Reaching your goal weight on Mounjaro, Tirzepatide, feels like the finish line, but stopping is not the same as being done. The real question is direct, short-term weight change or a long-term pattern of regain. The answer changes the next dose. The safest answer is usually not stop or stay forever, but planned maintenance with your doctor today. First, separate weight loss from weight maintenance. Losing weight means the dose helped you eat less than your body uses. It does that by reducing appetite and constant thoughts about eating. Maintenance means your body now tries to defend its old weight. Hunger, cravings, portions, and blood sugar can drift back before the scale shows it. That is why a goal number should not trigger an automatic stop. It should make you and your doctor review why the treatment was started. Was Mounjaro prescribed for type 2 diabetes, for weight loss, or for both? Those are different medical decisions, even when the injection feels like the same weekly habit. I'm Dr. Kim, a licensed physician. This is not medical advice. Consult your doctor. Mounjaro works through two hormone signals in the gut that affect appetite and blood sugar. In the United States, Mounjaro is approved for type 2 diabetes. The same active ingredient is approved as Zepbound, Tirzepatide, for long-term weight treatment. That difference matters when discussing long-term use. The medication does not erase the appetite and weight pattern that pushed weight upward. It turns down appetite signals, slows how fast your stomach empties, and helps many people eat less. When the dose is lowered or removed, those signals can return. That return can be quiet at first. The first sign may not be the scale. People often relax tracking, protein intake, strength training, and follow-up visits as hunger signals return. The scale may stay flat for weeks. Then waist size, snacking, or late-night hunger starts moving first. A trial tested this pattern. Some people stayed on treatment and others stopped. People who continued Mounjaro maintained or lost more weight. People switched to placebo, an inactive treatment, regained a meaningful amount. Many patients want the medication to become optional the moment it succeeds. But obesity often behaves more like high blood pressure than a short infection. When treatment stops, hunger, cravings, and weight regain can return. The person may blame willpower, while the real issue is the body's weight regain response. So the decision should split into 3 tracks: stop, lower, or continue. Stopping may fit someone who used treatment for a defined period, rebuilt habits, and has follow-up. Stopping may be riskier with diabetes, severe obesity history, high blood pressure, or repeated regain after dieting. If regain worsens breathing pauses during sleep, stopping can also affect nighttime breathing. A goal weight can hide a fragile plan. The lower number does not prove the old weight pattern is gone. It only proves the current support worked. The trap is simple. Success can look stable before maintenance is tested. Do not stop suddenly just because the scale looks good today. Discuss stopping if side effects are significant, nutrition is poor, or another medical issue changes the risk. Discuss continuing if blood sugar control, appetite control, and weight stability depend on the medication. Continuing the same dose can be reasonable when weight, blood sugar, appetite, and side effects are stable, but continuing without a clear reason is not a medical plan. The question is whether the current dose still protects health enough to justify its cost, side effects, and effort. Lowering the dose is not the same as failing. It may reduce nausea, constipation, or feeling unable to eat normal foods. It may also help if you are below goal, losing strength, or struggling to eat enough protein. But it should be tested as part of maintenance, not guessed in isolation. Maintenance works better as a test, not a guess. Pick a target range, not one magic weight. Many doctors track appetite, waist, strength, and blood test results. One higher morning weight means little, but a rising month-long pattern matters. Before lowering or stopping, write down 3 numbers: current weight range, appetite level, and recent lab results. Without starting numbers, you cannot tell whether the change is working or slowly failing. Those numbers make the follow-up visit concrete, not emotional. Then choose a review window. 4 to 12 weeks is often more useful than judging 1 week. During that window, watch for hunger returning, portions growing, exercise dropping, or blood sugar rising. If any two of those changes worsen together, the new plan may not be enough. Those changes are not equal. The main decision is which problem needs control. For one person, that is blood sugar. For another, appetite and weight regain. For another, it is side effects or poor nutrition. The same goal weight can point to different choices. Safety problems need a separate pathway. Slow regain can be watched over weeks, but side effects need faster attention. Persistent vomiting, dehydration, severe constipation, gallbladder symptoms, or pancreatitis symptoms should not be ignored. Pancreatitis means pancreas inflammation, often with severe persistent belly pain. Gallbladder pain is different. It can mean right upper belly pain, fever, or yellowing eyes. If meals become tiny, protein becomes difficult, or strength drops, the dose may be too strong. The point is not to lose muscle, strength, and daily energy. Cost and access belong in the same safety conversation. If cost forces stopping, say that directly. Your doctor may choose a slower dose change, a different dose, or a written follow-up plan. Stretching injections without guidance can create confusion and rebound hunger. Insurance rules can create a forced change. A patient may be stable on one dose, then lose coverage or supply. The next steps should be written before the final pen is used. Restarting later is not always simple either. After time off, the same dose may feel stronger than before. Nausea, vomiting, or poor intake can return if the old dose is resumed too quickly. After access, side effects, and dose changes, return to the reason treatment started. That reason should decide which numbers and symptoms you follow next. A diabetes prescription needs a blood sugar safety plan. A weight-only prescription needs an appetite and regain plan. For people with diabetes, the blood sugar plan matters as much as the weight plan. If Mounjaro is reduced, EA1C, a 3-month blood sugar marker, may need follow-up. Morning blood sugar before food, kidney function shown on blood tests, and the rest of the medication list also matter. Weight alone is not enough. Other diabetes medicines need review too. Insulin and sulfonylurias can lower blood sugar directly. Sulfonylurias are pills that make the pancreas release more insulin. If appetite or meals change, low blood sugar risk can change with it. For people without diabetes, the focus is different. The key question is whether appetite and weight stay stable after a lower dose or a stop. If the answer is yes, a lower plan may work. If the answer is no, continuing may be the less risky choice. Across both groups, the worst plan is pretending there is no decision. Some people keep injecting out of fear, even when side effects are eroding eating. Others stop out of pride, then feel ashamed when hunger returns. Neither reaction is a medical strategy. The point is not to prove you can live without medication. The point is to keep the health gains without ignoring warning signs. A maintenance decision should reduce panic, not create it. After the celebration fades, use a simple rule. Stop with monitoring, lower with a range and review date, and continue for clear blood sugar, appetite, or weight benefit. Medicine, simplified. That's what this channel does. If you want more, hit subscribe. This is not medical advice. Consult your doctor.